Today, I'm very excited to introduce Dr. Theresa Stone and Dr. Shalini Allam. Dr. Stone will be talking to us about culinary medicine, creating a recipe for nutrition. She received her medical degree from Georgetown University School of Medicine and postgraduate training in internal medicine at the MedStar Washington Hospital Center. After observing her patients adopt healthy lifestyle interventions that reversed or decreased progression of chronic illness, that made a tremendous impact on her, and she has gone on to a career that includes nutrition. As a member of the board of directors of the American College of Lifestyle Medicine, she addresses health advocacy and health equity in vulnerable communities. She received training at Harvard's Clinician Chef Coaching Program, the Benson Henry Mind Body Institute, Georgetown University School of Medicine, Mind Body Medicine and Culinary Teaching Kitchen. She serves as the medical director and co-developer of Fresh and Savory, a culinary and lifestyle medicine shared medical appointment pop-up teaching kitchen program at MedStar Health Lafayette Center, and leads Georgetown University School of Medicine and MedStar Associate Wellbeing Initiatives. Her team advises sports performance athletes in culinary education and lifestyle skills. She's an active member of the Teaching Kitchen Collaborative and Teaching Kitchen Research Conference Planning Committee. She worked with colleagues to introduce plant-powered living to the healthcare community with the Capital City Plant-Powered Challenge. We are very excited to have her speak to our group today. Thank you very much. Oh, and then let me introduce Shalini Allam, who's an all-star. She is currently serving as a chief medical resident in the Department of Internal Medicine, and I know that there's no way that we could run this place without her expertise and talent. So thank you so much, Shalini, also for presenting today.
Thank you, Dr. Wilson. We're glad to be here.
Good afternoon, everyone. So I'm Shalini, one of the chief medicine residents. I'm working with Dr. Theresa Stone today, and we're going to talk about culinary medicine, creating a recipe for nutrition. Firstly, in terms of financial disclosures, we do not have any. But our objective today is to talk about a few different concepts of culinary medicine. It's an up-and-coming field that both Theresa and I have been very passionate about, and she recruited me very early on in residency, trying to talk about culinary medicine on various levels, including patients, med students, residents, physicians, and everybody in between. So for our talk today, we're going to talk about a couple different things. The first is give a little bit more background of what culinary medicine actually entails, talking about education, where we stand in our education from medical students, but also in GME, various concepts that we want physicians to come away with after this talk. Additionally, like with every good teacher, we want to create resources for our residents, our attendings, and our patients as well. And then talking about where we hope to see culinary medicine go in the future. So talking a little bit about what culinary medicine is, it's a field of medicine that is new, but it's mostly focused on the translation from nutritional research to an at-home kitchen setting. The idea is to help our patients learn about the art of cooking, which is obviously an art form that has existed for millions of years, but now fusing it with the field of medicine to create healthy lifestyles for our patients. A lot of times when we're looking at institutions that have culinary medicine, and I know that MedStar has been doing a great job of initiating a lot of these projects too, the teams are really diverse. The same way we have interdisciplinary teams on the wards, we have interdisciplinary teams in culinary medicine. What's unique in this situation is that these teams have chefs, dietitians, physicians, medical professionals, and members of the community. So the problem that we tend to see in our patient populations is that they're in the constant struggle of having to figure out how to make a choice in their diets. A lot of times I'll see in patient education packets, it'll say eat healthy or have less than X many grams of salt or potassium or whatever the element is that we want to try to make an impact on. But whenever I ask patients, how does that translate into your eating at home? A lot of times they're not really sure. They're like, 2 grams, I don't have a way to measure that at home. I don't know how to measure that if I eat a hamburger. How do I figure that out if I'm at a restaurant? Another thing that they talk about is how their culture plays a role in this. A lot of times we recommend, I think you should stop eating rice. I think you should stop eating bread. But there's a huge cultural component of those things that preclude them from making certain changes. Another thing that we should take into account that I know Terry is also really passionate about is taking socioeconomic status into account when talking to our patients. A lot of times as physicians, we might not ask, like, how do you go about getting your food? Do you have limitations? Are you on things like food stamps, and how does that play a role in what is available to them? And then finally, even asking, like, is there a grocery store nearby is another topic that I as a physician haven't really asked my patients much either. So these are just concepts to keep in mind as we're going through why culinary medicine has become an up and coming field. So in terms of opportunities, culinary medicine is a unique way to help patients put health into their own hands. A lot of times they want to feel ownership over their health, and this is a really big opportunity to help them do that at home that isn't necessarily a pill or getting blood work or having to go to an appointment. And then again, it's really bringing up a topic that we don't speak about much in a clinical setting. The goal of culinary medicine is really, and a little bit more, Terry's going to give us more background about what she does for hands-on learning for a lot of these patients and really bringing medicine home for them. And then remembering that culinary medicine could be a family-oriented therapy. It could be something that people do with friends, family. It doesn't have to be the patient alone. And then another thing that has personally been relevant for me as a recent graduate residency is the fact that culinary medicine is a way for our future physicians to learn how to live healthy lives. A lot of times we are stressed, we have busy jobs, there's long hours, so learning to prioritize your health as a physician is a great way to serve as an example for our patients. These photos are actually taken from my medical school. The top picture is a garden in a home community that one of our physicians started, and they provide vegetables to a local food pantry. And then the bottom photo is some of my classmates from medical school and I in a teaching kitchen, learning to make varieties of meals from the same ingredients and repurposing it in various ways to fit different people's dietary restrictions. So talking about culinary medicine and medical education, there's been a number of articles over the last few years talking about where we are in our education. So this is an article from the Lancet in 2019 talking about medical education in a systematic review. And what they did is they looked at a variety of studies between 2012 and 2018 from around the world, including USA, Europe, the Middle East, Africa, and Australia. And they sought to understand how comfortable do medical students feel with giving advice on nutrition. Universally across the board around the world, there was a challenge with medical students feeling comfortable giving recommendations. They felt they were not sufficiently educated to give enough information to patients, regardless of the country, the setting, or even the year of medical education. And this could span up to people who have finished medical school and are actually in clinical training. You know, in terms of figuring out why this is important, they actually talked about how this can lead to like a huge knowledge gap for our patients. And then even non-medical organizations like Harvard Law created a book in 2019 in their food law and policy clinic. And basically they talked about how they felt that they actually made an argument towards the federal government to advocate for more funding to go into nutrition education for physicians. What they did was they looked at the financial impact of lack of nutrition education and how much our healthcare system from a financial standpoint would benefit from physicians having better nutrition education. They talked about how this knowledge gap is actually considered what they believe as a violation of the public trust, because a lot of times patients will come to physicians seeking this advice, and we give them the advice that we genuinely believe to be true and we from our understanding, but because we don't have that basic knowledge, a lot of times they feel like this is actually a missed opportunity to invest in better population health. Another point they made in the paper was how Medicare actually is the single largest contributor to GME in the United States, and in 2015 provided $16 billion to GME, but they only use about 15% of their federal spending. So one of the policies that they advocated for in this paper was to see if we could increase our funding for that. And then another popular paper, Circulation, this is a cardiovascular paper, talked about how many physicians were willing to undertake the task of diet counseling, but also felt like they didn't have a good, credible source for diet information that they could check on regularly. So this paper was more focused on how education can actually lower the risk of atherosclerotic disease that many patients probably didn't even realize to be true. So rather than just focusing on what we don't have, I also want to focus on what we do have. So there are a number of hospitals, and including MedStar, who have taken initiative to build our education with nutrition. From my personal experience, I remember I'm from Florida originally. I learned a lot about Tulane University and their initiatives. They have the Goldring Center of Culinary Medicine, and this was the first time I had personally heard of an institution who created a culinary institute, created a culinary curriculum that was for both medical students and people in the community. So they hosted teaching kitchens. They had physicians incorporated into the class, whether they were teaching the class or actually participating in the class. And it led to a lot of trust in the patient population there. The patients felt like the physicians were investing more in their personal health, and led to a really good collaboration in the community. Again, I just brought back my home institution, UCF. This was a collaboration between the College of Medicine, the YMCA, UCF's College of Hospitality Management, as well as Nemours Children's Hospital. It was a big collaboration, but taught medical students how to create healthy diets for themselves, but also for their patients. And some of the things that I learned in this, I still incorporate today into my practice. And then bringing it home, so this was in 2019, Theresa and I were at these sessions where the Georgetown School of Medicine actually started a culinary medicine class of their own. The students loved it. They were really enthusiastic. I think we actually had way more students turn out than we even expected, but everybody showed up. They would cook together. It was a great bonding experience, but then they would also review evidence-based medicine and papers and talk about how do they apply that in clinical context when they're seeing patients. So Terry provided this slide, and I think it's a great example to show that there's a number of different ways that these culinary medicine can be incorporated, from hospitals, big name hospitals like Mass General, Dartmouth, MedStar Health at Lafayette Center, to even community programs like Compass Group and Maine General Medical Center. And like I said, we actually worked at the YMCA as well, and they're always very open and willing to have people participate. So the other, now the next thing I want to talk about is concepts in culinary medicine, and what are some of the things that I would want our physicians to take away. A lot of times we have slides like this when we think of culinary medicine and nutrition. This is the slide that I had in medical school, listing every vitamin, where they come from, and what's the deficiency. And we typically get it on board questions, and it's kind of a memorization. I remember my lecturer in med school said, "I'm sorry, but this just comes down to memorization." And Obviously, we're not giving this talk if we believe that. So there's a lot more that goes into culinary medicine than just memorization. These things are important, but I think the thing we really want to focus on here is what is going to make it successful for patients to make change. So things to keep in context when you're giving patients advice on culinary medicine are the resources, is this like a practical change for the patient? Do the patients have the resources like we talked about? Do they have a grocery store nearby, or do they have transportation to get to the grocery store? Are they disabled? Are they even able to physically get there? Sometimes it even has to come up to conversations like, is it something they can afford? How many people are in their household? So a lot of patients are hesitant to bring these concepts up with physicians, not only because of how limited our exam times can be with them, but it is a lot of times an insecurity. Another thing to think about is evidence-based medicine. We want to make sure we're giving recommendations that have some evidence, and we'll go into that. And honestly, culinary medicine can't be summed up in 1 hour. So there's a lot of studies out there that go into various diets, how that's helped with outcomes. And I think Terry has some more information on that as well. Education, it's important to make sure our patients and our physicians are both educated. And we have some resources to hand out to you all about that as well. Finally, gold mindset. I really think that this is one of the biggest reasons why patients have a hard time changing their diet. You have to assess if a patient is ready for that change, and do physicians feel confident in their advice? And a lot of times I think from those studies, we find that we don't completely feel comfortable with some of our recommendations. The support system for our patients is also essential. It really takes a village to help somebody change their lifestyle. I was talking to somebody the other day about this, and if you're asking somebody to quit smoking, it's a lot harder if they surround themselves with people who smoke. Same thing goes with alcohol too, and the same thing goes with food. So if you're trying to ask somebody to stop eating McDonald's, then it's going to take more than just them. It's going to take their community that they spend time with to also stop eating McDonald's. And then the last thing is, again, like going back to what is the patient's motivation for change. There's a whole, again, course on what stage of change and contemplation somebody's in to make certain changes. But delving into that too, asking patients, what is your drive to change? And whether it's a fear of a family member who had a certain disease, or there's a million different, or if it's just I want to lose weight and feel better about myself. Those are all valid reasons and motivation. So this is something that I love this slide for a number of reasons. It's something that you can easily print out on a piece of paper and hand to a patient. It's not super wordy, and it's very like colorful and brings attention to help people understand, how should I start? Like, what's one easy step before even getting into, okay, you need to cut out XYZ, just asking them, how do they arrange food on their plate? How much space on your plate is taken up by vegetables? How much is protein? And sometimes I quantify that by saying, how many spoonfuls of rice do you put on your plate every day? Somebody will say 4 or 5. And I say, well, why don't we try cutting that down to 3? Is that like a reasonable goal for you to meet this portion of the plate? There has been studies about like the psychology of plate size and how that affects how somebody feels full or not. So even asking somebody, if you don't feel comfortable, like maybe you should start by just using a smaller plate and see how you feel. And then one quick, easy thing I tell my patients too is try to make the most colorful plate as possible. A lot of times, if you just tell them if it's colorful, then you probably have a good amount of vegetables and whole grains and protein. And that's just like an easy rule, especially if you have kids, to try to help incorporate that into their lifestyle. And then there was this concept called SMART goals, which I used almost every day in medical school and still use now. It's a way that you can help your patients every time you see them create meaningful goals and then monitor their progress over time. So the concept is that you have SMART stands for specific, measurable, achievable, relevant, and time bound. And there's a lot of like good and bad examples you can look at out there of what a SMART goal is. Somebody will say like, I want to be fit, so I'm going to start running daily. And we think that that's a specific goal, but it's really not specific enough to be something that you're monitoring. So an example that you can say for a SMART goal is, okay, I want to lose X amount of weight, or I want to eat this many spoonfuls of rice, down from 5 to 3. So that's like a very specific, and it's a measurable goal to say I have achieved this goal or not. Make sure that the goal is achievable. Like if you're saying I want to lose 30 pounds in 2 months, like that's really challenging to do for a majority of patients. So helping the patient say, hey, like this is not like a one-time, you have to make your life goal right now. This is a goal that we're going to keep checking in on every time we have an appointment, and let's see where you're at in attaining that goal. And I think one of the tricky parts here that we often miss about in our goal discussions is if it's time bound. So having like a start and end date. We hear this a lot in the context of quitting smoking. Like I'm going to quit smoking on December 1st. Okay, great. But this can also apply to culinary medicine as well, saying like by August 2nd, I'm going to try to incorporate more vegetables, like X amount of vegetables. I'm going to eat 1 salad a day instead of no salads per day. Something like that could be a really easy way. At MedStar, I actually have a dot phrase that I just put into all of my patient education documents. So it's a really easy way for you to be like, your SMART goal from this appointment is this, and filling it out for them. So they have something written at home and they can take it home to their family and say, these are my goals for myself. How can my family help me achieve these goals? Okay, so Terry's going to talk to us a bit more about resources for physicians and for patients.
All right, so I'm going to talk a little bit about culinary medicine programs around the country and some resources, and also things that you can do if you don't have access to a culinary medicine program. So this is Gable's Institute of Integrative Medicine in Chicago. Stephen DeVry is a cardiologist who was practicing for 25 years and kept seeing the impact of lifestyle and poor nutrition in his patients and developed this Gable's Institute. He offers, and he really believes that it's very important for us as physicians to learn about nutrition, to learn the motivation and interviewing skills that we can use for our patients to change their habits, and to see the changes that they can make after adopting a healthier diet. This is our program at MedStar Health. We call it Fresh and Savory. It's been around for about 4 years now. Here in the yellow is our chef educator, Chef Anthony. And it's a very low-cost pop-up teaching kitchen with induction burners, bowls, sets of knives, and patients learn how to cook and eat healthy. It was launched in 2017 with our MedStar Institute for Innovation. And we base it as a shared medical appointment. So initially it started as an answer to one of our cardiologists who was getting frustrated seeing his patients come back with progressive disease despite the best standard of care. And so for his cardiology patients, we created this 8-week program. It's 2 hours every session. And in addition to culinary skills, they also learn about lifestyle skills. And so we have a short talk on exercise, stress reduction, in addition to cooking. And as I mentioned, it's a shared medical appointment. And so in a shared medical appointment, patients have an opportunity to build community. Community is shown to improve behavior change. And several schools and hospital systems around the country have come together to form something called the Teaching Kitchen Collaborative. And so there's about 40 institutions around the country that have either very grand million-dollar teaching kitchens or smaller pop-up teaching kitchens like ours. And what you saw before was our virtual teaching kitchen in 2017 to 2019. And then in 2020, we converted it to a virtual teaching kitchen. So this is Chef Anthony doing a demo for our patients. Now that it's virtual, we're able to make the program more scalable. So I'm working now with 20 patients virtual. They're working from their kitchens now, so they're able to swap ingredients better. We feel like it increases their cooking skills. And then another physician joins us, Sue Beretti, and she has a group of 20 patients in Southern Maryland. So we come together and then we divide our patients into breakout sessions. What we found is we were a little bit worried when we switched to the virtual, but we were found, because we know that building community is so important. But we found that when we put our patients in these breakout sessions and they're cooking together, it really fosters a sense of community. And some patients have continued even after the program, even after the 8 weeks is over. And again, as I said, it's a shared medical appointment, so most patients are seen as a group, and they share recipes with each other, they share challenges with each other, and patients are shown to have an increased satisfaction, and the physicians in the program have had increased satisfaction as well. And then for education, the Gables Institute offers 4 modules that I think are very, very low cost, like $50. And so as physicians, we can take these courses, and they also offer free programs for patients as well. Physicians Committee for Responsible Medicine is an institute that offers a robust amount of patient-facing education as well as physician education. What I really like about the Physicians Committee for Responsible Medicine is that it's very, very culturally rich, and so they have, healthy Indian food, healthy food from the African American community, food really from all over the world, and so and all of this is free. So how do we get away from this? So, we have all this science. We know about the Adventist Health Study. We know about the Lion Heart Study, where patients were on a Mediterranean diet after their first MI had a decreased recurrence of heart attacks, strokes, and unstable angina. We know about the Adventist Heart Study. But although we have all this data that we know that when people eat a diet rich in fruits, vegetables, nuts, beans, we still have a high intake of overprocessed food. And so at Fresh and Savory, we try to introduce rich, fun foods, and we try to get away from the stigma that healthy food is not delicious. So one of our favorite recipes to make is this curry chickpea dish that we'll share with you, but this is a nice dish of quinoa that's rich in protein. It has, I think there's chopped herbs in it. We often make, this is our mango salsa. It's a hit that's often patients really, really seem to enjoy and share with their family. And this is a fruit smoothie dish that is great for breakfast. And then if you don't have access to a culinary kitchen, we have lots and lots of resources. This is a great handout that patients really enjoy. They can actually see what eating from the rainbow means. And so eating foods that are orange with rich beta carotene, or lycopene, tomatoes and red peppers. Anthocyanins, which the Rush University in the MIND trial shows that anthocyanins decrease people that eat lots of berries with rich in anthocyanins have decreased risk of Alzheimer's. And then this is another favorite handout for patients because they get confused with carbohydrates. And so they think, oh, carbohydrates are so bad. But if you look at this, this is wheat. And so this is the bran. This is high in fiber. This is the germ. And this is the endosperm. So what happens with refined grains is the bran with all the B12 and fiber gets away. The germ, which feeds the cell, gets away. And we just have this white part. And that's what a refined grain is. That's the carbohydrate. So we go over this with patients in the room and then show them types of delicious barley and brown rice and quinoa. There's a new rice that's becoming very popular. A lot of people from West Africa have been bringing it in. It's almost like the new quinoa, and that's called fonio. But it has a nutty flavor. It's really delicious. Also, we've also learned that mindful eating helps patients eat slower and enjoy the food. I know that a lot of times we're in a rush, we grab our food and we don't even realize what we ate. But studies show that when women are obese, just practice eating mindfully for just 12 weeks, that they continue to lose weight even after the study was over. So even after 6 months and 12 months, they continue to lose weight. And so this is from Insight Timer, and they have a wonderful series on mindful eating. And we have a couple of some of our favorite recipes to share with you. One thing that we recommend is some time-saving tips. And so one tip that we learn in culinary medicine world is repurposing. And so repurposing is you have one ingredient, one main ingredient, and then you make different meals out of it. So this is garbanzo beans. It's rich in fiber and high in protein, 8 grams of protein in 1 serving. And you can make some roasted chickpeas. Very quick and simple recipe with a little bit of cumin, a little bit of olive oil, and it's great for salads. It's also great for just eating plain. All right, so this is these are the multitude of trials that I was speaking of earlier. And then just to go over a little bit, the blue zones look at places in the world where people just live to be well into the hundreds. And they look at some of the commonalities. And so they're in Okinawa, Loma Linda, California, Sardinia, and Ischia, Greece. And they look at like, in addition to living in community, being quite active, they also have a very diet that's heavily focused on fruits and vegetables, small amount of nuts, small amount of meat or fish, and beans. It sounds like every one of the communities has a diet that's rich in beans. And then another study that I thought was really interesting is a gastroenterologist from University of Pittsburgh, Patrick O'Keefe, had 2 populations of patients, African American patients in Pittsburgh, and then he was also in KwaZulu-Natal in South Africa. And he noticed that the incidence of colorectal cancer in South Africa was almost 0. In his patients in Pittsburgh, it was quite the opposite. And so they did a fascinating study they switched the diets. So the patients that had the diets that were rich in fruits and vegetables and root vegetables in South Africa, they swapped that with the patients in University of Pittsburgh that were having the standard American diet was high fats, processed meat, and fried foods. And within just 2 weeks, they looked at the microbiome, and the microbiome had biomarkers of anti-cancer and anti-inflammatory markers. And so there was a low hydroxybutyrate, which is actually something very, very good. So the patients in South Africa developed a decrease in hydroxybutyrate. And that's fascinating to see just in 2 weeks how those changes can happen. And the other thing that we really want to press is that study after study shows that physicians can be the role models for the patients. So patients tend to do what the physicians do. If someone really believes strongly in using sunscreen, they're going to use it, and then patients are going to use it. And so there have some small studies that show that when physicians believe strongly in eating healthy and in cooking, then that translates into their patients, and the patients have better outcomes, particularly in diabetes. And another thing, just having an apple on your desk can motivate patients to eat out healthier. So the power of influence is really phenomenal. And also, if you don't have time to, if you don't have access to a culinary medicine program, then a food prescription works well. So using Shalini's steps of SMART goals, something specific, measurable, attainable, relevant, and time really works well for patients. And so if you feel like they're ready to make the change, and they're ready to change, you can write down a simple prescription. Also, you want to, we found that adding something to the diet is much easier than take it away. So if you say, okay, I'm going to stop having pancakes every day, it's much easier to say, I'm going to add blueberries. So you want to start where patients are and add rather than take away. And this is quite important because you want to also start where the patients are. So you want to make sure the food's culture relevant, not time consuming, and also affordable. This 2-question validated screening tool for social determinants of health is actually, we actually have it in Cerner. So we'll ask 2 questions. Were you worried whether your food would run out before you had money to buy more? And the food that we bought did not last and we weren't able to buy anymore. This can predict chronic illness and poor outcomes. But you don't want to ask the social determinants of health or for food insecurity unless you have resources. And so in Cerner, if you ask for the social determinants of health, and then if patients have a positive answer, then it will link you to community services according to their zip code. And also, a lot of programs are developing food pharmacies. So in MedStar, we have one in Baltimore where patients that are found to have food insecurity go immediately to a pantry. They get free food for 10 meals for 2 weeks. They meet with a dietitian, and then they see videos of a teaching kitchen with some of the recipes from the food. And other places for culinary skills and nutrition tips, there's a lot of good courses online that are free. And Kaiser Permanente has a really good blog from a lot of their physicians that are practicing lifestyle medicine, particularly Linda Shu. And then there's a couple of great physician blogs that review nutrition and culinary medicine. Michelle Hauser at Stanford has a great blog called Chef in Medicine. And this Eat Fresh is a great website that helps people that are on food stamps, so it helps physicians with patients on food stamps how to be creative and make food that's very inexpensive. Other resources for free online cooking is this great website called Switch. So 2 chefs that are really, really passionate about eating healthy developed this online program that you have to pay for called Ruby. And then in their own health journey, developed a healthier eating pattern of more fruits and vegetables and developed this free online website. And so to go with repurposing, so you can make the roasted chickpeas that could have like popcorn or add to your salad. You can saute the chickpeas and make a nice curry dish. And then you can put it in the curry chickpeas in a blender with a little bit of the fluid from the chickpea water and make a nice, and add a little, some sesame seeds, either ground sesame seed paste or grind some sesame seeds and make a nice hummus. And this is the Aquafaba I was mentioning earlier. So you just take, and it doesn't sound like it would taste good, but it's really delicious. So you take ground chickpea water, the chickpea water, take a blender, blend it up, and then add a little bit of vanilla. Some people add a little bit of maple syrup, and it makes a nice, healthier version of a Cool Whip topping for fruits, for a nice bowl of fruit. So thank you very much, and we're glad to take questions now.